السلام عليكم طلاب المحاضرة الأولى للفطريات Medical Mycology أستاذ مساعد دكتور وفاق الوتار. The objective of this subject is to deal with the superficial skin infections caused by different group of fungi and how to learn by collection of samples in the most appropriate way in order to reach the lab viable to be cultured to reach to the diagnosis. And the last subject in the objective is to test the proper way of using antifungal drug by disc diffusion technique or MIC method in order to apply good treatment in appropriate time to achieve cure. Dermatophyte generally they are considered a superficial mycosis, that's to say they infect only the superficial skin of a layer of skin, that is the dermis and the epidermis, and they have affinity to keratin. So it will be seen in area where there is keratin, skin appendages like hair and nail. Tinea is a term referred to a rounded dermatophyte caused by lesion. That is to say, any lesion caused by dermatophyte considered to be tinea. Tinea has been referred to different area of involvement, and they are usually rounded or circumscribed lesion with elevated scaly edges, sometimes associated with itching and sometimes they are not. We mentioned that the fungal infection of the skin have affinity to keratin, so they are localized on those area and make sure to be applied in this area for a long period of time unless appropriate treatment have been given, and the treatment is given for a period not less than 4 weeks, from more 4 to 6 weeks, and most of drugs are fungistatic, requires to be accumulated in the lesion for a long period of time to achieve at the end of the course a full complete recovery. Tinea is classified according to the site of involvement in the area of human body. If it is involved all the area of the body except the head and the palms and the foot, they are considered to be tinea corporis. This is a picture showing a toddler with multiple lesions all over the body caused by different tinea corporis lesion. They are rounded, infecting extremities, trunk, scaly, pruritic, with erythematous edge. The center start to be cured while the lateral edge or outer edge always active and extending laterally in order to achieve more invasion of skin. Usually if you want to take scrub from this patient to send it for culture, you should take from the periphery, the active edges, because the center might be cured later and return normal. Usually this infection could be transferred from human to human called anthropophilic, or from a pet animal to human called zoophilic. The most common genus causing this disease is a trichophyton, and one of them is Trichophyton rubrum, which is the commonest. This is another tinea lesion infecting the foot. It has been shown in the big toe in this area, as well as in the other middle and the other 3 toes, and sometimes it will extend into the the dorsal aspect of the foot, scaly, erythematous, associated with pain and pruritus. This is another lesion shown in the infection of the hand, but it is usually seen in the area of the nails. So they are called tinea anguium, and the nail will be deformed, whitish in color, curly, easily breakable, brittle, and disfigured. As we see it there in this hand, we have a nail involvement called tinea anguinum of the thumb. Another picture, tinea capitis, that's to say the involvement of fungal infection in the area of a scalp where there is a loss of hair and erythematous scaly lesion shown in this UV light room where it is shining a special type of light under UV source, and this is called tinea capitis. This is another tinea capitis lesion with well circumscribed fibrotic cornified lesion seen in a Negro patient, and usually with the scaly edges and elevation with cornification, superadded bacterial infection, sometimes pus, sometimes we got development of cornified horn area called the chorion, and they are usually good responding to treatment with the griseofulvine antifungal fungostatic drug. Tinea cruris is a tinea involving the crura of the body. الكرورة هي المثاني، يعني ممكن يكون in the axilla as well as in the in between the thighs. So they are well circumscribed lesion, and they are burning and pruritic because of wetness of the area. As we see here, between two legs we get this irritating red color vascular lesion, sometimes with pustule, sometimes with bacterial infection, and with raised edges, and usually they are transferred from one human to another, so they are called anthropophilic, caused by epidermophyton flocosum, trichophyton mentogrophyte, and the previous one we know it is the trichophyton rubrum. This is a classical picture of tinea cruris of the thigh. It could be available also in the upper picture here in the axilla, very well circumscribed lesion with erythematous edge, scaly, pruritic, sometimes a superadded infection. What caused this lesion to be persistent is the wetness of the area and lack of humidity and covered with the clothes, and this is very common in the elderly patient or athletic patient who are kept in thick clothes for a long period of time. Tinea barbi is a term referred to this patient condition where we have development of multiple rounded lesion caused by superficial mycosis in the area of mustache or the area of beard. They are anthropophilic or zoophilic in course. And here very advanced state of beard involvement with tinea barbi. They could come from a barber with infected utensils or towels, so he could transfer disease from one patient to another, very disfiguring, very bad shape, and it is usually a treatable condition. Tinea manuum is infection of the hand, and the palm are commonly involved as they are dry, scaly, erythematous, and could be transferred from one human to another, and they could be an extension by chronic itching of a lesion in the foot from the athletic foot, or occasional condition dealing with a pet animal like a dog or a cat or a rabbit, any hairy animal available, or a domestic animal like the cows or the sheep, and sometimes the camels and the horses, caused by trichophyton rubrum, which is the most common one, epidermophyton flocosum, microsporum canis, which comes from canine animal, microsporum gypsum comes from the environment, T. mentogrophyte, and T. verrucosa. This is a typical lesion where the hands involved directly by the dry scaly lesion, very irritating, sometimes gives burning sensation and pruritic and dryness. A clinical manifestation of this condition could be seen in case of this presented tinea pedis. We have erosion, we have burning sensation, we have chronic papulosequematous hyperkeratotic area, sometimes we have vesicles, and sometimes we have acute ulceration as we see here and there. There is an ulceration here, there is multiple fibrosis, and there is also a lot of vesicles all over the leg, disfiguring, painful, and very hard to deal with them without treatment. This is a very simple state of superficial mycosis called tinea versicolor, and they appear in a form of multiple dark patches over the lower part of the neck until the waist, from the anterior and posterior aspect of the trunk, and sometimes it would extend to the upper one-third of the arms, and usually called spaghetti and meatballs under the microscope. As you see, there is a multiple yeast and multiple hyphae, just like a spaghetti and meatball. This is easily diagnosed and easily treated, and it's common, very common in the young age group with a lot of sebum secretion. Ecology of dermatophytes, usually they are considered to be obtained from one of the three sources we mentioned them before, from human to human, or from animal to human, or from environment to human: anthropophilic, zoophilic, and geophilic. The anthropophilic associated with the person-to-person contact, mostly in toddlers and children at school, where they share combs, hats, cups, etc. The zoophilic come from dealing with animal, as we mentioned, from the cats, dogs, and jackals, wolves, and domestic animals like cows and cattle, as well as from some horses and camels. Geophilic usually comes from the soil. You contaminate your hand or leg with the soil and you obtain a direct development of a lesion, which is very common. Geographic distribution is a worldwide problem, and they are considered to be classified according to the genera causing them. Trichophyton, it involves all the layers of skin. Microsporum, it involves the hair as well as the skin. And epidermophyton, it involves the nail mostly. The trichophyton species, here we maintain the three area of infection, and they look like under the microscope a long pencil shaped conidiophore. Conidiophore هي حافظة الأبواق. It contains multiple septum, transverse septi, and they have a very thin wall, and they have the pen or pencil shape. On culture, you get this fluffy, nice, cottony, white color colonies on the Saborodixtros agar when they are cultured, and the laboratory on low temperature between 18 to 22 for a period not less than 10 days, with the addition of antibiotic inside the media to prevent the growth of bacteria. Here we have a slant of various type of dermatophyte. This is Trichophyton rubrum. This is Trichophyton mentagrophyte. Start as single spot, and after 2 weeks from incubation you get this very nice fluffy and extending hyphal edge, very diagnostic and pathognomonic, with a red color in case of Trichophyton rubrum in this tube. A few words about Trichophyton rubrum. It causes a chronic infection in patients with a very little cell-mediated immune deficiency defect, mostly seen in patients who are black as well. But this is a disease of Negroes with defected immune system. This is a picture of developed, well-circumscribed lesion of tinea capitis caused by Trichophyton rubrum. Microsporum species, they are 13 in number, involving the skin and the hair only, and they are cultured on Saborodixtros agar. They will achieve very big colony, whitish in color, less fluffy, less cottony, and wrinkled in the center. While the pathognomonic feature is the development of thick wall, spindle shape, multicellular conidiophore حافظة أبواق مغزلية الشكل، والسطح مالها الخارجي يكون خشن in order to be stuck to the surface of the skin or hair and develop the lesion. Microsporum canis is one of the species of Microsporum present in the canine group, and by this rough edges they will stuck to the hair of the animal and transfer to the human and develop very serious chronic persistent tinea lesion. This is a disease of white personnel rather than black in the previous one. Usually, the last genus is Epidermal Flocosum. We have only one species responsible for skin and nail infection, and this is very nice color of the colony, attaining a violet wrinkled colony with well circumscribed edge. Under the microscope, you look for the special shape, that is to say ricket shape, and contain a little number of microconidia, not more than 4, and they have a special club shape or tennis racket shape. with a smooth outline. Look, for the outline is very smooth. This is diagnostic. Once you see this type of conidiophore, you should say that this is an epidermophyton flucosum, which is the only pathogen for a human. Therapy, we mentioned about the therapy previously, griseofulvine, which is one of the drug of choices and given for at least from 4 to 6 weeks. It is fungostatic, applied orally, systemic application, and the patient should take the whole dose and buy it and put it at home to use it daily by the appropriate dose. In order to achieve recovery, you should at least maintain therapy for 3 weeks because it is fungostatic and keratophilic. It will be accumulated inside the keratin and kill the fungus gradually. If we cut the treatment, the disease will be reactivated and you get no benefit, and sometimes the patient will worsen the symptom after inappropriate interrupted treatment. We have another tinactin, clotrimazole, miconazole, ketoconazole, itraconazole, and tribnifine, which is very nice drug applied in form of capsules available in the market, acceptable price, and very good response will be achieved in a lesser period of time. 10 days you can in 10 days you can get improvement of the lesion, but you should continue for several weeks as well. This is a nice picture showing how the fungi living under your nails, so they are waiting for you to scrub or touch your skin in any area to attain a tinea lesion in a period of 1 to 2 weeks. So be careful. You should be careful from these fungi entering under your nails, resulting in a lesion. We have a few words about a non-fungal lesion called dermatophytid reaction. This is an immunological reaction to already existed superficial dermatophyte infection. For example, I have an infection on my feet, that is to say tinea pedis, but I develop another ring lesion in area of the hand. This lesion on the hand, if I culture it, it will be negative. There is no growth because it is an autoimmune reaction to the antigen achieved from the original one. If I treat tinea pedis, I will get recovery from my hand lesion. This is very characteristic. It is an immune reaction. Just like a tuberculin test, you get infection in the lung and you apply tuberculin in the skin, you get an immunological reaction. And the mode of action really, not in the principle of the agent. Here we have a culture technique. We scrub the edge of the lesion and we take it inside a paper or a glass tube or on a slide or from contaminated brush, culture directly on seborrheic dextrose agar, and you will achieve a very good colonies after a period of at least 10 days. This is an ectothorax infection when you get intact hair shaft and a lot of spores of the fungi growing outside the hair shaft. This is usually seen in tinea pedis. We have a few notes about dermatophytes finally. They are not necessarily seen in athlete to be called an athletic foot. Could be seen in soldier, in case of jungle workers, in case of archaeologists, seen in patients who are in policemen kept in shoes for a long period of time. Tinea mouth does not mean that it is an eaten skin lesion. It is a superficial fungal infection, and sometimes it goes ringworm. Does not mean that there is a parasite or a worm inside it. This is only a term. Thank you very much for attending this lecture. See you in the next lecture will be given by me about endemic mycosis.